Good evening, and welcome to this Ask the Expert event focused on stroke education and thrombectomy, a life saving treatment for certain types of stroke, now available here in the Fredericksburg region. Tonight, our experts will explain how to recognize stroke warning signs, what to do in the moment, and how thrombectomy can help appropriate patients. We'll also be answering your questions live. To submit a question for our panel, simply drop it in the chat here on Facebook. Let's meet our panelists. First, we have Susan Halpin, the Stroke Services Program Manager with Mary Washington Healthcare. Next, we have Dr. John Muse from Mary Washington Neurosurgery. Dr. Muse is a highly specialized neurosurgeon with thrombectomy capabilities, helping to bring world-class stroke care here to our community. And last but certainly not least, we have Dr. Omar Saeed, a board-certified vascular neurologist and the stroke medical director of Mary Washington Healthcare. Welcome, and thank you all for joining us this evening. Susan, I'd like you to start tonight's program. For viewers who may be new to this topic, what is a stroke and why is acting quickly so critical?
Thanks, Addie. Well, I would say a stroke is when blood flow is blocked to a certain part of the brain, and that happens suddenly, or a blood vessel bursts in the brain, and that deprives the brain of needed oxygen. And so it's really important that we act quickly so that we can save brain cells from dying, because every minute a stroke goes untreated, about 2 million brain cells die.
And so, what are some important warning signs people should watch for?
Well, that's a good question. And I always direct people to the acronym Be Fast because it really helps them to remember the signs of stroke. And also, it's telling you to be fast or reminding you to act fast. So I'll go over those just so it's easier to remember. The B stands for balance. And with stroke, things are happen suddenly. So this would be a sudden loss of balance or a sudden loss of coordination. E stands for eyes. So sudden vision loss or sudden blurred vision. F would be sudden facial droop. It stands for face, so one side of the face drooping. And with that, we ask people to smile to show their teeth, and you're really looking for a droop on one side. And then A stands for arm. So this could be arm weakness to one arm in particular or numbness to that arm. And then S stands for speech. So loss of speech, slurred speech, garbled speech, or they just don't understand what you're saying. And then the last letter is T, and that stands for time. So it's time to call 911. So we try to educate people that even if you just have one sign of stroke, to call 911. It is a medical emergency. And there's a saying in the stroke world that time is brain. So that's why we want to act so quickly so that we can treat you and save your brain.
That's great to remember. Be fast. We'll remember that. Dr. Saeed, what are the main types of stroke and how do they differ in terms of treatment?
Thank you, Eddie, for having us. So good question. So we have two types of strokes. There's the ischemic stroke and the hemorrhagic stroke. So there's about 800,000 strokes in the U.S. every year, and the majority of these are ischemic stroke, more than 80%, the rest being the hemorrhagic strokes. And the ischemic strokes usually occur when there is a blood vessel in the brain that is blocked, usually by a clot. And in those cases, our goal is to restore blood flow as quickly as possible. And that can be either from a clot busting medication that we can give them if they're within the time window, and or by minimally invasive procedure called mechanical thrombectomy that Dr. Muse will talk about more. The other type of stroke is the hemorrhagic stroke, which is about 20% of the strokes in the United States. And this is basically bleeding in and around the brain from a ruptured artery, a blood vessel in the brain. And the focus on treatment for these patients is a little different. Our goal is to stop the bleeding, control the blood pressure, and reduce pressure in the brain, and sometimes even surgery. So even though they're both called strokes, the treatments are very different, and which is why rapid diagnosis is very important.
Thank you so much, Dr. Saeed. And I know you mentioned thrombectomy. So, Dr. Muse, what is a mechanical thrombectomy in simple terms?
In simple terms, it's just removing a blockage from inside the blood vessel. Believe it or not, back in the 1960s, we're doing these procedures, but through an open surgery where we'd open up the skull, go in, physically remove the clot, and then sew it back up. These people didn't do too well. And over time, we've developed these new techniques that are essentially minimally invasive techniques where we can go in from inside the blood vessel, all the way up to this blockage and then remove it with basically a tiny little vacuum or a little basket that will grab it and we can then pull it out.
Excellent. So, who may be a good candidate for a thrombectomy?
Yeah, so not everyone is a candidate for thrombectomy. Certain types of strokes are, and they're what we call large vessel occlusions. And these are the most devastating types of strokes because without treatment, it's 90% morbidity or mortality. They're in the large vessels going up to the brain that supply things like function for moving your arm, moving your leg, being able to speak. There's also a time component. Right now, we do these up to 24 hours. We've got really good data that shows us that people have a great benefit from doing these strokes, and we call them wake-up strokes. So they, up to 24 hours are considered eligible. And some, depending on certain circumstances, we'll extend that as well, depending on kind of how things are. And there's ongoing studies now to see if we can extend that time period as well. The extent of the stroke when someone gets to the hospital determines whether or not they'd be a candidate. So if they already have a very well-established stroke, then opening up that vessel isn't necessarily going to help anymore, potentially could cause harm. And then someone's overall health. If they're at very poor health, very limited function already, it wouldn't really be appropriate to necessarily put them through a procedure. So it's always important that we have conversations with them or the family before doing this procedure, see if this is what they would want done.
Thank you. Yeah, a reoccurring theme I keep hearing tonight is, speed in responding to this. So, when minutes matter, mileage shouldn't. So it's incredible that we now are able to offer this procedure locally, close to where all of us live in this community. So thank you. Susan, what does a stroke program or team do to help make care faster and safer?
Thanks, Addie. That's a good question. We have a great stroke team at the hospital, but we think of our stroke team as part of a stroke system of care, and really that involves the relationship we have with the community and with our EMS providers, and it all really starts with the community. So educating the public on stroke, like we're doing tonight. May is Stroke Awareness Month, so we're really glad to bring this information in May. But educating the community on those signs of stroke with Be Fast and calling 911 if you have any of those signs of stroke. And the reason why is because our EMS partners are trained to recognize stroke, and they will arrive quickly, assess the situation and the patient, and then they call the hospital, give us a heads up. Hey, I think I have a stroke patient coming. And what that does is get the stroke team at the hospital ready. We're ready for that patient to come in. Everybody's ready. It's a real coordinated process, and the patient will come in, will give what's called a stroke alert, and ours is a code stroke, and it's an announcement that goes overhead, and everyone on the team arrives. So we've got our neurologist is there, our emergency physicians are there, the nurse, the medic, tech, and it gets everybody ready. So even our radiology department is ready. They're ready for that patient to come in and get quick imaging. We have pharmacy on hold for medications. Lab is there, and of course our neurologist and neurosurgery too, just in case we need a neurosurgeon. So everybody's you know, on the scene, and it's not a process that's step by step. Everything really happens all together. And last year at Mary Washington ED alone, we had just shy of 600 code stroke cases in the ED. So we're very well versed at our code stroke process, and it's something we continue to work on because we have new guidelines coming out all the time, and we're trying to get patients seen quickly so that we can make really quick decisions. I mean, Dr. Saeed and Dr. Muse are making very important decisions very quickly to give the patient the best outcome.
Oh, yeah, that seems like some amazing coordination that's happening. Dr. Saeed, let's talk a little bit about prevention and risk factors. What are the biggest risk factors for stroke?
So another good question. So one of the biggest risk factors that patients have is stuff that we already know, but we tend not to pay too much attention to sometimes. So high blood pressure, smoking, diabetes, high cholesterol. In the older population, we see atrial fibrillation, which is an irregular heart rhythm, obesity, lack of exercise, and poor sleep, especially untreated sleep apnea. So high blood pressure is probably the most important risk factor because it increases the risk of both the ischemic type of stroke and the hemorrhagic type of stroke. And, the good thing about all these risk factors is that they're modifiable, meaning we can control them, we can help uh, correct them so the patients have a reduced risk of stroke.
Thank you. That's incredible. Dr. Muse, let's talk a little bit about myths and misconceptions. What is one myth you hear often that you'd like to correct?
Yeah, I think one that there's not really a treatment for stroke is one thing that for a long time there wasn't. I think that's largely changing now. People realize that. Uh, and then also that it's too late to help. That, it's already been going on for too long, so doing something about it isn't going to actually have any benefit. Even if you're beyond that 24 hours that we talk about, there still could be an opportunity to provide treatment.
And I would ask probably the same question of Dr. Saeed and Susan, since you guys are so ingrained in this world of stroke. Is there anything that you wish patients or families of patients understood sooner?
Susan, you want?
Okay. Well, for me, I also facilitate the stroke support group, and I think I'd like people to know that stroke isn't just a disease of the elderly. We have a lot of young stroke survivors in that stroke support group. So, it can happen to younger people, and it does. So, that is a common misconception as well.
Yeah, and I'd like to add the problem with patients. Sometimes patients have symptoms of stroke, and they wait, and that's probably the biggest mistake that they make. So if you look at the statistics, only about 20 to 30% of patients actually make it to the hospital on time for us to treat them. So out of 100 people who are having strokes, we are only able to treat 20 and 30 patients because most patients, what happens is when they have these TIAs or mini stroke symptoms or even stroke-like symptoms, they think they're going to get better. So they wait, and we tell them not to wait. And the other thing is they try to drive to the hospital, and we emphasize the role of EMS and 911 because we have this stroke system that can pre-alert us and we can be prepped to move rapidly.
That's amazing. Thank you. And for our audience who heard Susan go over the BFAST, the signs and symptoms earlier, please let us know in the chat if you'd like it, and we could drop the BFAST in the chat so that way everyone can have access to it. It's also on our website, neuro.mwhc.com. So thank you, panelists. Now we are going to, I hear from our webmaster that she's already done that. So please feel free to save and take a screenshot of the BFAST. Thank you to our panelists. Now we are going to move into our question and answer session and answer questions submitted by our live audience. As a reminder, you can drop your question in the chat at any time. We will try to get to as many questions as we can. If we are unable to get to your question tonight, we will make our best effort to reach out to you in the next few days with an answer to your question. So, Susan, I think this first question is going to be for you. If I think someone is having a stroke, should I drive them to the emergency room or call 911?
Oh, that's a good question. And it's really a common one we hear, right? People don't know what to do. And the best thing you can do is call 911, right? And just as we mentioned, our EMS providers are so well trained in stroke. They'll arrive, they'll be able to start taking care of the patient. And most importantly, they'll be able to call the hospital, take you to the most appropriate hospital for you, which is a stroke certified hospital. So I always say call 911. Even if you just have one symptom of stroke, even if the symptom goes away, call 911 because that could be a TIA. And we know that the risk of stroke is really great after you've had a TIA. So we want to make sure we, do the workup, find out what's happening so that we can prevent a real full on stroke from happening.
Susan, for our audience, can you explain what a TIA is?
Yeah, a TIA, as Dr. Said mentions, a mini stroke. It stands for transient ischemic attack. It has the same symptoms as the BFAST. So You could have, arm weakness that it just feels weird. You can't lift your arm. It's just not able to do the same thing as the other arm, and it comes on suddenly. These stroke symptoms happen right away, and maybe it lasts for 5, 10 minutes and goes away. Or you have difficulty speaking. All of a sudden, you can't speak. There's a video that is around there about a newscaster that is having a stroke on air. She's having a TIA, but doesn't realize it, but she's having trouble understanding the teleprompter. She can't lift her arm. She's lost vision in one eye. Everything happened suddenly, and her coworkers called 911. And by the time she got to the hospital, her symptoms had resolved, and they did a big workup on her. So they did the right thing by calling 911.
And Dr. Saeed, speaking of TIAs, they're often referred to as mini strokes. How seriously should someone take a TIA?
So very seriously, and like Susan said, they may be mini strokes. So the meaning of mini stroke means that there was a clot that blocked a vessel enough to cause symptoms but not damage. And so in these patients, usually when we get MRI imaging, we don't see any permanent damage to the brain compared to an ischemic stroke that does cause permanent lasting damage. And the reason it's very important to come to the hospital when you have even mini strokes or TIA-like symptoms is because these patients are at very high risk of having a stroke within the next 48 hours, a bigger stroke. These are usually warning signs. Actually, up to 10 to 17% of these patients end up having a stroke within the first 90 days. So, you have a very increased risk of having another stroke that could be more serious.
Thank you, Dr. Saeed. Dr. Muse, I think this one would be for you. How soon does a thrombectomy need to happen?
Ideally, as soon as possible. The longer we wait, the more likely that there could be permanent damage. But this quickest that we can, get people there and onto the table, the better. So that's why, talking about these stroke systems of care, we're working hard to work with EMS to get these patients here, especially if we're suspecting a large vessel occlusion. And the sooner we can notify people at the hospital, they can notify Dr. Saeed, and then he'll give me a call, and then I can start getting people moving towards the room so that we can get things set up and ready to go in the event that it is a stroke that's eligible for a thrombectomy.
Excellent. Thank you. Dr. Saeed, if someone has already had a stroke, what is the risk of them having another?
So it's more than anybody who hasn't had a stroke. Obviously, these patients tend to have higher risk of future strokes. But the main thing is to identify what was the cause of their first stroke and to prevent them from having another stroke. And this may mean, so like I said, the risk factors, right? So if the patient had atrial fibrillation, you put them on stronger blood thinning medication. For some people, it may mean antiplatelet therapy, which means like aspirin, lowering their cholesterol, controlling their blood pressure, lifestyle changes, which I think we underemphasize, should be emphasized the most. And that is, quitting smoking if you smoke, exercising regularly, healthier eating, which is very, very important. And like, I mentioned in the beginning, 80% of these strokes are preventable from just modifying these risk factors. And so if you've already had one, you want to know, the big question you want to ask is, why did I have this stroke? There's so many times in the hospital that patients will come in and say, hey, I had a stroke. And I asked them, did anybody tell you why you had the stroke? 90% of the patients are not told why they had the stroke. And I don't know why. Either they don't remember, or no one really mentioned, what happened, what caused the stroke. So I think identifying what caused it and correcting that is the most important.
That's excellent. Thank you. Dr. Muse, this is kind of a unique question. I have a history of stroke and want to start a family. How will this impact my pregnancy journey?
It's a really good question, and it's something that's not often recognized because you are at a much higher risk of having another stroke and of having a complication during your pregnancies. And so it really is a situation that would ideally have multidisciplinary care. And it just so happens that at Mary Washington, we have one of the national experts in women's health and neurology here that has established this type of clinic and is going to provide that care to be able to guide women through that process and to understand what the risk is, what needs to, need to modify any risk factors, need to be changes in medications. And so it's really something special that we can offer here now.
That's incredible that we're helping to close the gap on neurohealth for women. So thank you so much. All right. Well, we're coming back to the end of our time here tonight. So thank you to our panelists, Dr. Saeed, Dr. Muse, and Susan Halpin, for sharing your time and expertise tonight. And a big thank you to all of you, our viewers, for tuning in to this Ask the Expert. If you take one thing away, let it be this: learn the warning signs and act quickly. Stroke is a medical emergency. And be sure to follow Mary Washington Healthcare on Facebook and our other social channels for more health and wellness information and future Ask the Expert events. Thank you again for joining us. Until next time, stay safe and healthy and have a great night.